Maggie is our presenter today. She is a faculty member at Berman Institute and the Department of Pediatrics. She's almost entirely, but not exclusively, Hopkins trained. So Hopkins Medical School.
That's true.
Not undergraduate, NPH from the School of Public Health, then went off and did bioethics training at the McLean Center at the University of Chicago and at RWJ, among other things. And it was our great and amazing good fortune when Maggie came back to Johns Hopkins and joined the pediatrics and then the Berman Institute faculty. Maggie has been working incredibly hard over the past couple of years with other devoted colleagues that I'm sure she'll mention here at the Berman Institute to do incredibly innovative work in the teaching of ethics to residents. If there's a group of learners that hopefully should be and receptive and ought to be attended to very carefully in medical ethics education, it's people after they finish their formal training, whether that's in medicine, nursing, or other areas, when they're first exposed to the real responsibilities of taking care of patients. And yet it's an area where, as a field, we have not been anywhere near as innovative and as creative as we should have been. Maggie and other of our colleagues, who she'll mention, I suspect, have been central to doing that, and it's that work that we're going to hear about. So please join me in welcoming Maggie.
So I really appreciate being here, and it's always interesting to come and talk to this group because I feel completely free when talking in this setting to present problems and not solutions. So I'm going to ask some questions today about a topic that we need a lot of help with, and the question is about evaluating ethics education. So we know that ethics education is always sort of the first on the chopping block in residency education and curricula generally, and that's one of the reasons is that it's sort of less tangible than teaching a surgeon how to tie a knot effectively or teaching a pediatrician the vaccine schedule. Ethics is a little bit different. It is a little bit intangible, and I think people are quick to sort of say, well, that one we're not so sure about, let's take it off the chopping block. So one of our concerns, because we know this, is that if you can evaluate something, if you can show outcomes, if you can prove that ethics education makes a difference in the care of patients, then it's much less likely that it will be considered sort of intangible and be the first thing on the chopping block. So that's an important goal for those of us who believe that ethics education is sort of obviously good, because it's not obviously good to everybody else. We need to find a way to make sense of it and to convince the world. High-quality ethics education really should be effective. In fact, we ought to be able to show some notion of efficacy. But what we mean by effectiveness is very elusive and not always clear. So what has happened, I think, as we develop curricula for ethics education, we have in the back of our minds all the time that we have to do something that we can evaluate. And so the question I'm presenting today, I'm going to show you some programs that we've developed and are evaluating. But the question now is sort of, is this the wrong direction completely? Is this focus on evaluation going to create more problems than solutions for us in ethics? I hope the answer is no, but really you'll see when we get focused on evaluation, I'm going to show you what happens. Okay, so at Hopkins, but I'm not going to talk about that today. Today I'm going to focus on both general surgery and pediatrics, because those are the two for which we've done the most formal curriculum development and are embarking on the most formal evaluation program. So the notion of curriculum development for medical education is sort of interesting. When we started on this, we actually did a formal course in curriculum development. The reason we did it is that a whole lot of curricula in ethics, if you look at them, if you can see how they've developed over time, are just sort of, they feel like a hodgepodge or a little bit of an ad hoc presentation of whatever the teacher feels like teaching. So we decided because we had the great good fortune to have some funding to really do this in an appropriate way, we started with a formal approach to curriculum development. So what I'm going to do is show you how the first, I think, 4 steps of curriculum development for pediatrics and surgery we did together. And then for the implementation phase, we had to separate because they're very different programs with very different needs. But I'm going to talk about the curriculum development and how it guided us towards evaluation, and then show you how the evaluation works. Okay, so the first 2 steps are problem identification and general needs assessment, and that then needs assessment for your targeted group. And in this situation, our targeted group was residents at Hopkins, and then very specifically surgery residents and pediatric residents. And please feel free to interrupt me anywhere along the way if you have questions, comments. So the general needs assessment for ethics education in residency training is that people in medical school, everybody in medical school has to get some ethics education. But it's very, very inconsistent in medical school and tremendously inconsistent in residency training programs. Most pediatric programs say that they teach ethics. Some surgery programs, when we started this, probably about half surgery programs said that they did teach ethics. Now it's about 80 to 90% of surgery programs say they teach some ethics to their residents, but it's very sketchy, very patchy, very difficult to identify exactly what's happening. For residency accreditation, you have to say that you're teaching ethics. But the ACGME sort of puts it under the notion of professionalism. I never liked that, because I don't think that they're the same thing. I certainly don't think that ethics is ever under professionalism. But it really tells you that even for the ACGME that does the accreditation process, ethics is sort of a vaguer notion. So they feel as though they can identify professionalism more powerfully and concretely than they can identify ethics. It does not sit well with those of us who focus on ethics. The curricula in residency training generally is widely varied, and the focus has always been, in every training program that we saw, the focus has really been on high-stakes, sort of tertiary care problems, the rare and the weird things at the beginning and the end of life, not what people encounter on a day-to-day basis in clinical care. And most of it's not based in any sort of empirical evidence. Again, it's just sort of, well, we've always taught this. We've always taught the Dax case about a burn victim who doesn't want care. We've always taught, we've always taught the same things. Instead of really thinking again, as medicine changes, as clinical care changes, what are the new needs for ethics education? And there has been little evidence published of effectiveness. And actually, a lot of the evidence that's published shows that it's actually not very effective. That people finish residency training and say the ethics education they got actually is not helping. So that ought to be disturbing. Here's a little bit of that data. Sorry about that. This is just the evidence that current ethics education may not be effective. There's a lot of discussion that moral judgment declines with training, that the hidden curriculum in medical school and residency training programs belittles ethics, so that you may think you're learning ethics, but you're attending or your senior resident on the wards, sort of their behavior and their practice and their response to ethics issues makes ethics seem stupid and seem unnecessary. So that's the notion of the hidden curriculum. It's sort of how the structure of training, how the structure of care puts ethics really at the very bottom of a very long list of important things to consider. Pediatric residents have reported dissatisfaction with ethics training. I would like to point out, not my pediatric residents, but somewhere. A more targeted needs assessment for our specific programs of surgery and pediatrics. Again, everybody, we did a baseline survey of our pediatric and surgery residents to identify sort of where they stood along the range of knowledge and attitudes about ethics. It turns out everybody's had some training in medical school. Training was varied. They had basic, their basic knowledge was okay. They could do multiple choice questions about some basic stuff. Their confidence about responding to ethics issues, their self-reported confidence was pretty variable. And the frequency with which they identified ethics issues in clinical practice was pretty variable. Everybody favored small group discussion as the way to learn ethics. We also got input from the program directors as part of our targeted needs assessment to see what these programs needed, what the surgery program wanted, what they were able to offer us, how they recommended we structure training, and how the pediatrics program recommended we structure training. Okay. So after we finished our targeted needs assessment, we started to get a sense of what it is we wanted to do, but then we needed to sort of come up with our goals and objectives to make sure that the education that we were offering was coherent. So we looked a lot at people who have written about the goals of ethics education, and this is from Edmund Pellegrino, written in 1989. I still think this is the best list of goals for ethics education I've ever seen, and we really adopted this with some variations that I'll show you as our set of goals. So teach the skills of ethical analysis essential to making medical moral choices, raise sensitivities to ethical issues, enhance critical reflection on your personal values and your obligations as a physician, and then to identify the substance of ethical assumptions underlying clinical decisions. If we could get this done, I would know that we did the right thing. This is a huge target. At Hopkins, we revised this slightly to begin also because this number one is sort of not on Ed Pellegrino's list, but increase the awareness that competence in ethics is necessary. So I think at Hopkins is a wonderful institution and has a long history of providing fabulously interesting and fabulous care. But ethics at Hopkins, clinical ethics at Hopkins, has been a little bit more patchy. And it was never clear to me when I was a medical student or a resident here, and when I came back as a pediatrician, that the institution, the hospital really sort of got ethics. That ethics was really sort of integrated into the care of patients in the institution. So this notion that one of our goals at Hopkins, we had to actually start with increasing awareness that competence in ethics is actually important. I imagine that this group, that seems like a silly question, but really, in fact, for the hospital, this is not a silly question. So then we've accepted the enhanced ethical sensitivity and reasoning, build knowledge and skills. And then the other one, and I think this is an interesting one for us, develop a shared language for ethics. So Hopkins is big and complicated, and teams have to talk to each other. So if the surgeons are taking care of a pediatric patient, it would be great if they shared a notion of ethics, if they shared a language with which to discuss ethics. Because if you share the language, the likelihood that you'll have a conversation is much greater. Anybody who's traveled in anywhere knows that, right? So if you share a language with somebody, the likelihood that you'll open a conversation is much greater. So we're looking for a shared language about ethics for Hopkins. And this has been a really interesting goal, and it's not one of the things that we've evaluated yet, so I'm not going to talk a lot about it today, but it's been a big focus of all of our teaching to make sure that we're always using a constant language. Okay, so those were our goals, but one of the things that I think is obviously missing from our goals is this notion of practice. So we talk a lot about what we want people to learn, what we want people to understand, but even in our list of goals, if you'll notice, we left off the action portion, that people will actually provide better care to patients based on what we've taught them. That the ethics education they receive from us actually changes the way patients experience care in this hospital. Now, we didn't leave that off because we didn't think about it. We left it off because there's no way to make a goal of something that you know you can't evaluate, to know that you're not going to be able to measure, is sort of self-defeating. So we left it off, knowing full well that if you're talking about competence, you're really not talking about knowledge. You're talking about what you can do, right? And even, so this is Campbell's assessment, and this is Campbell's description. It's knowledge for habituation to action that leads to appropriate action. On the other side is Miller's sort of triangle of competence, and he starts with knows. So we're going to teach knows, see that the residents know how, see that the residents can show how, but are they really going to do it? So that top of the pyramid is always the goal. Can the education that we provide change what people actually do? Okay. So those are our goals. And from the goals, the next idea is to, based on your goals, what are your strategies? And this is where it gets kind of interesting because surgery and pediatrics are so very different. Generally, however, we really thought a lot about the sort of education that we wanted to provide. And I'm really struck by this. It was always funny to me that in medicine, we do so much teaching and have so little education about teaching. Right? So I teach and teach and teach and teach and teach. And really, maybe I've had 2 courses in education in my whole life. So it's really, we're not necessarily great teachers. So I think sometimes when there's an idea about education that we can really bring to the table, it really helps to clarify the goals and then the strategies. So I like this description of how learning works in medicine. So accretion is sort of what we do at medical school. It really does. It's sort of the old form of, let me carve out, open your brain and dump a lot of facts in there and see what you can do with it. That's what we do not want to do. I'm finished with that. I don't have any interest in that sort of learning. I don't want my students to have any interest in that sort of learning. We need to sort of say, okay, been there, done that, finished, sort of. Structuring is this notion of formation of new conceptual structures. So I really love this notion. So what I want to do is take a bunch of residents who have a basic understanding of the facts of ethics, and certainly a lot of experience to develop their own internal practice of ethics. What we want to do is offer them frameworks so that their ideas about ethics find a structure that can support them as they're sort of applying their own ideas to more and more difficult cases, to more personal cases, to their own practice. That's the focus of ethics education for us, this notion of structure. Tuning is, I think, what I hope people will do after they leave us, right? So you have to keep practicing, keep fine-tuning what you've learned, the frameworks that you've developed. But this notion of our job is to help people develop a framework that will support their personal practice of ethics has really helped focus the education that we're trying to do. Going along with that is this notion of adult learning theory, adult education. So we're trying to remember that we're not teaching children, but we are actually teaching adults with a lot is one of the reasons that I cannot bear it when people use television to teach ethics. We are so rich with personal cases. These residents have already, in their first year of residency, seen enough to write 1,000 TV shows. If we can get them to talk about their personal experience, then what happens is that they take this information back to their personal experience and learn to use their own frameworks, further develop their own frameworks. We want it to be empirically based, and I think I mentioned earlier that in our needs assessment, we realized that most education around ethics is sort of based in what people think they ought to teach, as opposed to what people actually experience. So we did some baseline work in pediatrics to get a better sense of what the residents are actually experiencing in the clinic, and we use that and a couple of things I'll show you to focus our educational efforts. Okay. The next thing on this list is the current curricular opportunities and limits in the program. So again, pediatrics and surgery we're focusing right now. We talked to the program directors about what they actually needed for ethics. Did they need anything? Did they want anything? What was it that they actually saw? And interestingly, of the two programs that we talked with, the answers are very different. Surgery was the first to say we have a lot of need and we will give you time and space and help to do it. Pediatrics, I think, pediatricians, we all know that we're the nicest doctors in the world, so we sort of assume that we don't really need ethics. So interestingly, in my own department of pediatrics, I had a harder time getting people to realize that this was important. I was successful eventually, but it took a lot more, and I think because the attitude, the general basic attitude was that we get this. In surgery, I think that they're always trying to counter the storybook picture of a surgeon that's harsh and unfeeling, and so they realized that they really wanted some very specific training. And then the last thing in the educational strategies was always this notion of what can we do that we can evaluate? Because if we start a project that we'll never be able to evaluate, we're never going to get long-term support for it. Okay. So in surgery, this is what we came up with. We came up with, surgery is very skills focused. So the interns have this really cool thing. Every Thursday morning for 3 or 4 hours, they have what I call it Pig Lab. But it's not always Pig Lab, but it's their lab session where they learn to do things. They learn to manipulate instruments and tie knots and cut things open and sew them back up. And so that, interestingly, the surgery department gave us some of that time. And this is really important because the surgery interns are so focused on skills development. The fact that the surgery program said ethics is a skill, we're going to give you our skills development time to do it, made a big difference because it really, I think, helped the surgery interns to hear what we were doing as important. It was the same as learning to tie a knot. We're teaching you the same sort of skills. We need you to think about this in the same way you think about the rest of your education. So the topics of breaking bad news and informed consent were topics that were identified on our baseline needs assessment as things that the surgery interns said that they experienced frequently but weren't all that confident about. So there were a lot of things that the surgery residents said they experienced frequently but they were wonderfully confident about. Other things that they hardly ever experienced and didn't really care about. But we chose these two because they were things that were common and about which the interns said they were not very confident. And additionally, those were two things that the program director said that she really felt as though all the interns needed to get much better at. So that helped us to choose those things. So the program is required for all interns, and that's another thing. It's not voluntary. Every single surgery intern is required to attend our session, which again really boosts its importance. In the same way that they're required to attend all the other skills development sessions, they have to come to ethics. The implementation, again, what we wanted to do, remember, is to help people build frameworks. So for breaking bad news and informed consent, there's lots of sort of established understanding of the right way to do it. But we didn't start by teaching, here's the right way to do it. We started by asking, what's been your experience with informed consent? What's been your experience with breaking bad news with patients? What have you seen that looks good to you? What looks bad to you? And so we had a very fascinating discussion with these small groups of surgery interns where they explained what they saw. And we used what they saw to develop a framework, a consensus framework from them, which was, interestingly, always very similar to the standard frameworks that are available. So the point of this was that the surgery interns, based on their own experience, understood it as well as anybody who was writing about it. And because we'd started with their personal experiences, they remained engaged in the whole thing. It was their knowledge that was having an impact on the day. So then after they've developed the consensus framework, we showed them how their framework matched sort of the standard knowledge. And then we practiced with a standardized patient, which always makes everybody groan, including me. The whole notion of like role-playing with a standardized patient gives me chills. not the good kind of skills. So, but they did it. They accepted it. They did it. We developed a case, a narrative case for this standardized patient, and each resident would practice or observe their colleague practicing. And then after that, they got formative feedback from their colleagues, from their teachers, from the standardized patient herself. And we've been doing this now for 5 years, and it's very well received by the residents, which I find fascinating. So here's just a comparison of the goals that we set up and the strategies that we implemented to achieve those goals. So increasing awareness that competence in ethics is necessary, that was really the idea that the surgery program director would say, you have to do this. This is a skill you have to develop in the same way that you have to learn to tie knots. That really helped us reinforce the notion that ethics matters. So enhancing ethical sensitivity and ethical reasoning, we used this notion of using their personal experiences to build the framework so that they could see when they said, you know, I really hated the way that I was stuck having to get consent, having to consent a patient 5 minutes before she went into surgery for something that I'd never seen, a procedure I'd never seen, and a patient I didn't know. So to hear that story and then say, so what's wrong with that? What happened? Why is that not okay? Really built that sort of, this is a horrible situation, into this is an ethics problem, and here's why. Here's how this works as an ethics problem. And so it really helped to, again, create that notion of sensitivity and help them to see how reasoning worked. The knowledge and skills, that was a practice with the standardized patients with formative feedback from colleagues and experts. And the last one, this notion of the shared language, that one we get to do in their second year of training. So we have, I'm not going to talk about it right now, but we have an opportunity for the 2nd through 5th year residents to do cases. And in the cases, we do our case analysis and use the method that we focused on, the shared language method. But I'm going to leave that off for today. Okay. So the step 6 was assessment and feedback. So what we did was a pre and post test during their lab experience. And the pre and post test was simple, tested knowledge, attitudes, and satisfaction, and a question about likelihood of that the practice will change. And here's some data from the first 4 cohorts. So, you know, this is the data that we have. So what we can show is that pre and post this 3-hour interaction, the surgery intern's level of confidence increased. Their confidence about providing appropriate information for informed consent, their confidence about the process of obtaining informed consent, their process about breaking bad news. In all of those areas, the surgery interns gained confidence over that 3-hour session. They also gained some knowledge. The scores on the knowledge test, the complex multiple choice questions that we asked, in every case, knowledge increased. Okay, so we can show this. We can show that this works. We can also show that they felt it was very useful. So on over time, for every single thing, it was they at least agreed that the session was useful for developing clinical skills, for changing their approach to breaking bad news, for changing their approach to informed consent. So that's the sort of data that you get with pre and post tests and a curriculum that's focused on sort of knowledge and skills development. What we have shown is that we can change knowledge and we can change confidence. What we have not shown in this is that we can change practice. We can show that they know how, because we see them with the standardized patients. We can see that they know how to do this appropriately. What we can't know from this at all is whether or not it changes the way they actually interact with patients and each other when they're on the floor of the wards. So it's assessment. I'm not sure it makes a huge difference. Or I'm not sure that we can know if it makes a huge difference. How's that? Okay, now let's switch for a second to pediatrics. Same sort of notion in pediatrics. The pedagogy is the same, adult learning focus, evidence-based, but the curricular opportunities were very different in pediatrics. So the opportunity was, I'm in pediatrics, right? So I'm there all the time. And I'm bossy. I can push back and keep pushing, keep asking, keep arguing to get what I want. And the residents in pediatrics are openly interested in ethics. There's no question about it. It's very easy to get them involved in a question of ethics all the time. But the limits, the residency program director would not give me any specific time for teaching. There was no curricular time. They were not willing to carve out any curricular time. They were supportive, but absolutely not committed. which was interesting. And also the hours restrictions are tight everywhere, and in pediatrics they are particularly tightly observed. So what do? So the good news in pediatrics, again, is because I'm there, what I could do was develop a program that was that involved me being available to teach at any opportunity. So anytime somebody cancels a new conference in pediatrics, I'm in, right? I schedule several new conferences over the year, but anytime somebody has to cancel or there's a problem, the chief residents just call me up because I'm always ready with a case, I'm always ready with a question, I'm always ready to teach. Attending rounds used to be a big burden for the people who were the inpatient attendings. So I would always offer, if you ever get tired, if you're busy, I'll do your attending rounds for you. And it got to be very routine that I would come in and meet with every ward team and take an attending round so the attending could go off and finish some other work, and I would teach. So all of that was working pretty well, mostly because I was available, which is not a great way to set up a curriculum, I'll just tell you. It worked, and it continues to work fairly well. Okay, the other thing that we did, though, was really work on the empirical basis for ethics education in pediatrics. So we did some work in the outpatient clinic with colleagues, including Holly Taylor and Joe Carissa and Mark Hughes. We all worked hard on this one to see what the residents were actually experiencing in the outpatient clinic. And from that we developed the themes, and I can use those themes then to focus my education sessions. Again, I'm not going to talk about that much today because it's not so much evaluation as the empirical basis. What we did develop for evaluation, though, is this narrative reflection project. So one of the goals of this project is to engage the residents as adult learners and to help us identify the issues that concern them the most. What the project involves is residents writing about their experience with ethics, both as interns and then again when they're in their second year of residency. One of the reasons we did this program is because we decided this would be fabulous if we could find a way to evaluate what the residents were thinking about ethics through their writing. If we can find a way to look at what they write at year one and look at what they write in year two and see if we can identify a change in the way that they reason about and analyze ethics issues. It was a fascinating project and iffy even from the start, but really if you're thinking about sort of a broad-ranging curriculum that we had in pediatrics, there weren't a lot of other opportunities for evaluation. So this is the one that we decided to go with. I'm going to talk about it today. Okay, so in the first year, the residents, we tell them to write a brief narrative of a case that felt like ethics to them. And purposefully, we don't tell them what ethics means at that point. Based on your previous experience, if something feels like ethics to you, that's what we want you to write about. And we want you to tell us sort of what happened, why it happened, what the resolution was, and what you think about the resolution. And then we ask them to do the same thing again as a second year. And in between the times, I mentor their writing. So I read their first one, I send them back notes, give them other things to think about, talk to them about it, and use the problems that they come up with, again, to focus some of my teaching efforts. Okay, so just focusing now on where we are right now in pediatrics, here's again this comparison of our goals and our strategies. So goals, raising sensitivity, we have ethics case conferences, didactic conferences, and this shared language around ethics. We had this really cool little how to be an ethicist card that tells you how to analyze an ethics case. I didn't bring one today, but it's a topic of another discussion. But it's actually a really cool thing. It's very much a standard format. It starts with why is this case bothering you? What sort of information do you need to understand what's happening in the case? And really focuses on the use of personal and professional values as you interpret what's happening with the case. And it's been that sort of common language approach has been very successful in getting the residents to talk with each other about ethics. Developing skills in analyzing ethics issues, we have this ethics card, and we always use the same framework in discussion when we're talking about an ethics case. And we use the same framework when we're doing the formative feedback in their writing. So developing the habit of critical reflection, one of Pellegrino's goals, this is that reflection process. Okay. And then learn to identify the values underlying clinical decisions. So in one of the foci of our ethics conversations is always how do your values impact the way you're interpreting information in this situation? How does your anxiety about adolescent abortion affect your impression of who this child is and who her parents are? So it's always part of the conversation because it makes such a big difference, and it's not something that is discussed often enough. Okay, now I'm sort of racing through to get to the assessment part of it because I want to talk about how we did this. So Holly Taylor was incredibly, I worked closely with Holly to do this and really we were approaching the content of the narrative reflections. So the residents, again, they wrote in year 1 and year 2. And we developed, based on some previous research not done by us, a rubric for evaluation of their narratives. And there were 8 domains of ethical reasoning that had been identified by some previous authors as sort of a good way to encompass the way ethical decisions in healthcare, in clinical care happen. So those are the 8 domains of ethical reasoning. So whether or not you can recognize ethical issues, which is sort of our notion of ethical sensitivity. Are you using a framework? How do your personal values impact this? How do you communicate around ethics? What is your perception of your role as a resident? Your perception of the therapeutic alliance between you and the patient and family? Your use of professional values? And your capacity to act on this. So challenge unethical behavior, push for ethical outcomes. And each of these domains was evaluated on 3 levels of achievement, and those are from work done by Goldberg. And so the traditional, reflective, and reflective. Let me explain what these are. If you're a traditional thinker, if your ethical reasoning is in the traditional vein, you're using concrete personal values or rules to guide your analysis. It's pretty much black and white, not ambiguous. This is sort of the way, I always think of it as sort of adolescent thinking, but it's not just adolescent thinking. It's really very much the way that people practice clinical medicine and clinical ethics as well. So just an example from the writing, we were looking at the domain of use of professional values. And so here's a resident who wrote, "We value the safety of our patient above all else. And so, and having established only a very brief relationship with the patient's mother, we weren't entirely sure how reliable she was, but the focus is really, it's the safety of the child above all else. Very black and white, nothing else mattered." We called it traditional reflective, which was sort of more expanding a little bit more awareness of conflicts and moral obligations. This notion of the right thing to do is to initiate the workup for a suspicion of abuse. I learned that in medical school. In fact, I'd be in trouble with the law if I didn't bring a suspicion up. But what about the ramifications? So I'm hoping you can see from the first to the second, sort of that opening the door into wondering about your role and wondering about your professional values and whether or not the black and white is actually correct. And then the third one, the more reflective, sort of the most mature approach to ethical reasoning. The question is, an underage patient with the support of his family refuse standard medical care. There's nothing magical about the age of 18. You can read the rest of it to really show that this person has a nuanced understanding of how to apply what they've learned in medical school about ethics, what they've learned in residency about ethics, to this case, that there's nothing is black and white. There's several viewpoints to be considered. So this one we would sort of give a score of the most sophisticated form of thinking. So we had, again, 8 domains. We did the same identification for each of the 8 domains in way too many interviews. It was fun. It was very fun. And what we found was that for 2 of the 8 domains, there was actually a significant change, a significant positive change between year 1 and year 2. Use of personal values and use of professional values. On both those domains, the residents got much more sophisticated with time. Those are statistically significant. The rest of them weren't. So the question is, did we not see a change in the rest of them because our rubric's not very good, because it wasn't a change, or because this was just a really difficult thing to do? To look at heterogeneous narratives from time 1 to time 2, looking for sort of standard change, is a challenging thing. But I think that what we learned from this was the notion of a rubric works. Maybe we don't have the right rubric, but the notion works. What we also noticed, and I think this is very important, is sensitivity and reasoning did not decline in any of those domains over time. And the reason I think that is so interesting is that there's a lot of writing about how medical education leads to a decline in ethical sensitivity, moral sensitivity, moral capacity. We did not see any evidence of that. And I think it's important because it's never felt very true to me that people's capacity for moral reasoning declines with education and experience in medical school. So I was happy to see that we could at least disagree with some of the previous research. One thing we don't know, though, is are any of these changes attributable to the education that we were providing? And that's sort of on purpose because we weren't targeting our education to these domains. We really wanted to see sort of how the residents changed independently and with some basic ethics education, really to see if we could measure this. So if we were to do this again, after more targeted education, we might get very different results. The point of this, though, is to say that with a focus on evaluation, this is the sort of stuff that you get. So in pediatrics, pediatrics, like surgery, what we have shown, what we haven't shown, I think what we have shown is that you can at least initiate an evaluation of ethical sensitivity and ethical reasoning. What we haven't really shown, because we didn't ask the question in pediatrics, is does knowledge change? But we could, I think this notion that you can evaluate changes in ethical sensitivity and ethical reasoning over time, you know, I think the notion that's possible is something that we focused on, and I feel confident that it's probably possible. Does it get to the top of the pyramid, the top of the triangle? Does it get to practice? Does it change practice for these residents? We don't know. So we're still stuck with, we can get part of the information, but it's very difficult to show that any of this changes the way a resident cares for patients today, and especially 10 years down the road, when it really matters. Okay. So I think we've done some pretty interesting work, certainly a lot of work, in trying to develop some frameworks within which we can evaluate ethics education and ethics practice. Still now, I'm left with this question, does any of this matter? What is it that we're trying to do? We've spent a lot of effort on evaluation. Are we going in the wrong direction? And that's what I want to sort of open this discussion to right now. Is the focus on ethics, on assessment and ethics education necessary? Is it valid? What are we missing when we spend so much time focusing on assessment of education? Is there another way to do it? And what are the next steps? So I want to open it to discussion right now and see what you guys think.
Before we do that, can I perfect timing, the floor is open. Thank you, Maggie.
Yeah,
You're on.
Thank you, Maggie. I've adopted your kindness, a lot of your curriculum with my pediatric residents at Sinai, and let me tell you, it doesn't work just here on Wall Street, it works down there too, so thank you.
Thank
You
you.
brought up something at the very end, that is my question. Do you have plans to go back and survey the peds residents, surgery residents, 5 years from now, 10 years from now, and see what they think? Have they maintained or retained? Have they, I think that might be an area of potential value.
I'm glad you asked that. In the last couple of years, we've sort of developed another focus to develop a standardized, a validated assessment tool for ethics, knowledge, and attitudes for residents everywhere. So we actually, this was a collaborative effort with several ethicists sort of all over the country. We developed a survey here of sort of I think we decided on 6 domains of clinical ethics and developed multiple choice and true-false questions for each of those domains. Sent all of those questions out to about 15 ethicists around the country and asked them to evaluate it, and went through this fairly complicated process of validation for the questions. So now we have a validated survey that we are now doing some collaborative work with 3 or 4 other programs to do for their residents now at baseline, and then this is something that we can use again 5 years down the road. The question though, this is still knowledge and attitudes, right? So it's still not practice. So the question of practice, really requires observation. And that's something that we haven't really been able to do. I mean, I would love to sort of stand behind a surgery resident for several hours and see what they actually do. But that, it's a wonderful idea. And I think that sort of that notion of the 360-degree observation is what is the holy grail of evaluation of competence. But you can, it's very difficult sort of to figure out how to actually do that in an educational setting. Yes?
How do your colleagues in the faculty like this?
In which the colleagues in pediatrics? Actually,
Surgery, either one. Both.
I'll talk about pediatrics first. So my colleagues in pediatrics actually have been pretty receptive. So the good news is this year, because last year when the hours restrictions got even tighter, we had to give up doing some of the inpatient teaching that I have found so valuable. And so scrambling to figure out another place to get enough education. In the outpatient clinic in pediatrics, the faculty there were so interested in the work we'd done before that they actually have allowed me to bring ethics education into the outpatient teaching curriculum, which again is a very tight curriculum. So they have been very supportive and actually interested in how to become better teachers of ethics. So that's, we're only starting that program right now, so it'll be very interesting to see how they accept it. In surgery, we don't really know, because one of the reasons we do this in a very particular way in surgery, we don't have any attending surgeons in the room when we do this work with the interns. Part of the reason is that the nature of the conversation is different when there's an attending surgeon in the room, because we're asking them to tell stories about things that have happened that have not gone so well, or about practice that they don't admire. So making sure that it's just us and no surgeons in the room talking to the interns has been important. So we don't have a lot of interaction with the surgery faculty at this point. There are several members of the surgery faculty now, though, who are interested in ethics, so we're hoping to sort of expand our program in surgery to incorporate them at least in part of the teaching. That's a good question. Yeah.
I'm going to challenge you in a friendly way.
Great.
I don't
promise
see
not
why
to cry.
ethics education has any special challenges that any other education doesn't have. And in the same way that from an instructional design perspective, you would have cognitive, affective, and behavioral domain competencies and learning objectives and develop a series of assessments linked back to those learning objectives or competencies. I think you can do the same thing here. And particularly in a medical education setting where you actually have those three domains that you have to assess in everything, medical education-wise, I don't see the special challenges here.
I agree. I don't think it's a special challenge at all. I don't think people do it very well in almost any aspect of medical education. So I've not been all that impressed. There are some, as this notion of competencies, develops and develops, there are some narrow areas in medical education where this is done really well, where there's wonderful assessment and that you can actually see outcomes that make a difference. But I'll tell you that there's a whole lot of medical education that doesn't even initiate with formal curriculum development. So I think I love the notion that assessment is important, because I think all of medical education needs to be brought up to snuff and to be considered again with an eye towards curriculum development, needs assessment, and evaluation. So I agree. Ethics is not exceptional here. I just happen to be focused on ethics.
But so just to take it to the next step.
Sure.
So the thing at the end that you said was most challenging was the behavioral.
Yeah.
But the behavior of ethics is up here. And so you could, for example, present case scenarios and look at the process the resident goes through in thinking through the issues and coming to some set of actions tied back to learning objectives around behavior, engagement, and process.
So we can do that with a narrative project. So that is one thing that we can do, because we're asking them to talk about their own experiences, which does make it more challenging. It's much easier if I used a standard case and asked all of my residents to evaluate a standard case and tell me what they would do. I just think that's a waste of everybody's time, because life is not hypothetical. I want them to learn about their own cases. So we've sort of decided to really use the adult learning notion of using your own experience as opposed to these hypothetical cases, knowing that it's harder to evaluate. But I think you're right. If we get this rubric well done, and if we get better at this format of evaluation, we have a chance to do that. And it's exciting.
So just an observation, often challenges in assessment or evaluation are really challenges in articulating competencies, sub-competencies, learning objectives, etc.
Yes.
And if you do a better job of that, then
It's easier to
obviously,
evaluate.
yeah.
Yeah, I'm not sure it's a better curriculum, but it's an easier curriculum to evaluate.
Exactly.
And really, it's a struggle. I can come up with a curriculum that's easy to evaluate. I'm just not sure I'm going to care about it.
Maggie,
Yeah.
I've heard you talk about the fact that the experience in the NICU is one which the pediatric interns most often bring up as causing them great moral distress and want
Yes.
to discuss it. But since this is something that comes up with such great frequency, does this offer an opportunity to work between the intern students and the faculty, the attendings, a broader group of the clinicians with whom they
Yeah.
might be interacting to look at what is troubling to them and whether there should be some modification in what is the behavior is in general?
Yeah, exactly. It's a really excellent point. And I've had some very good success in going to some of the divisions in pediatrics pediatrics, like the neonatology group, pediatric pulmonary, pediatric neurology, and sort of working with their faculty to do the same thing, to sort of look at their experience of ethics cases. Again, taking cases from their own, current cases from their own, that they bring to me, and offering them an opportunity to discuss this in the way that we discuss it with the residents in order, again, to build the shared language and to tell them what the residents are saying about their experiences in the NICU or, wherever else. It's, again, hard to carve out, to get that time, to find the, not my time, but to get the faculty to sit still and listen to these things, because they're, again, very busy and aren't really sure that ethics is what they need to be learning when maybe it's the latest research about something. So it's one of the things that I'm able to push in pediatrics, because I sit in pediatrics and I know these people and I can often wangle an invitation to come and talk at their meetings. Very much more difficult in departments where we don't have a faculty member. Like, this would be great in surgery if we could get somebody in surgery who could say, at their own faculty meeting, sort of, raise the ethics points all the time. It is, it's very much the need and very, very important in the way that we approach education here. And I think doable. It's just, it's casting a broad enough net to make sure we get the right people.
Maggie, how do you think the faculty, more senior faculty, does with these kinds of questions with this education? My concern is that you can teach the residents, but it's not going to have much effect if the faculty isn't paying attention.
Right, so we have a good chance to check that out now in pediatrics, because the outpatient clinic faculty has said they want to participate in this teaching. They want it in the clinic, and they want to do more of it. So we'll get a chance to see if we can help sort of. One of the pieces of research I didn't show today was some of the observation we did in the internal medicine clinic, in the outpatient clinic, where what was so striking was that ethics issues come up all the time in the same way they do everywhere. That's not surprising. But the teaching faculty there almost never identified an ethics issue as an ethics issue and taught about it. Almost never. Not because they don't see them as ethics issues. So interestingly, when we did interviews with them afterwards, they would identify these as ethics issues, but they never brought them up to the residents and talked about them. Almost never. Why? The why of that is fascinating to me. Like, what's happening that our own faculty in an institution like this are uncomfortable raising something as an ethics issue? We saw it in pediatrics, we saw it in medicine. It's a really important question. I don't have an answer. Yeah.
Question. We've mentioned a couple of things that, like the hierarchical relationships that might make residents uncomfortable with faculty and,
Right.
and other things about, the forced timing of informed consent. How much of this, maybe it's just a challenge in looking at how you evaluate action, but how much of it is that they don't have the skills to deal with it, or that their options are somewhat constrained by other structural factors of practicing medicine?
So the second one, that their options are constrained by the structure, especially in surgery. So the residents talk a lot about, the interns talk a lot about, I'm always being tasked to go get consent, 15 minutes before the surgery happens. I don't know the surgery. And they know that that's wrong. They all know, there's no question in anybody's mind, that is not the way to do it. They all want to believe that the attending has done it in clinic last week, done, appropriate informed consent, but they can't know for sure. So it's a little bit, because they're uncomfortable raising a big stink about it because they want to have faith that their attendings have done the right thing, and they guess that their attendings have done the right thing. So they're in a very interesting bind. So it's not, we work on developing skills around informed consent to make sure that they know how to do it the right way. But, their actual experience is constrained by stuff that we don't really understand all the time. Does that help? Does that answer your question a little bit? It's an important point. Yeah.
I wanted to extend this idea of the narrative project a little bit. Is there implied, or this has already happened, that the other side of the narrative might be from the patient's perspective?
Yeah.
So with the ethical issues that the residents might be encountering or talking about, you've already mentioned that there's their own perspective, professional and personal perspective, but is there an ability for them to recount what the patient's story is and how that informs the whole ethical situations going on?
I wish I had some, yes, then they do it. When the residents talk about, when they write about ethics, they're often writing about what the patient has said to them and how it changed the way they talked about things. It's actually very interesting, some incredibly compelling stories about the family narrative. The other thing that we're doing is actually doing some work observing ethics on the inpatient pediatric unit, where they do family-centered rounds. So the families are involved in the rounding process. We go around with them and listen and write down everything that we hear. And then we've had an opportunity to go back and interview a couple of the families to see what their experience of the whole thing has been as well. That's a very important part of the whole thing. It's always going to be one-sided until we really bring the family, the patient focus in. It's actually difficult to do it because you impose a lot when you sort of insist on listening to what's happening between a doctor and a patient. So it's a little bit of a delicate balance to be there without changing the way things happen. Yeah.
There's a component that I'm sad to say is almost never mentioned in discussions like this, and that is the role of paramedical staff who, it's two-sided. They can be your ally in dealing with ethical issues. They can relieve your time crunch sometimes by helping with that, and for sure, they get the fallout on the other end.
Yeah.
From the
very true.
families, from the patient, and it is hierarchical. They are all, if the intern or resident is afraid to speak to the attending, you can bet your bippy that the social worker is,
And then there's
and the OT person is, and maybe the nurse.
yeah.
But I see it from that perspective.
It's a
And
good
and if you can consider them as allies in helping you do your work, a lot more could get done and accomplished, and also in defining what the ethical issues are.
I agree, that's a good point. So we've worked, there's some people in the Bioethics Institute, some of the faculty there are very interested in this notion of combining training for allied health personnel, physicians, nurses, and everybody else. So this sort of across the professions, which I think is really important. So I've started some training when I work with some of the pediatric nurses. So I do several sessions a year with them to help to sort of bring them into the same discussion. And the times when we have a conference and we can invite social work and invite allied staff, it's fascinating because they do bring a different perspective, and certainly, as you say, are often the people that know the patient the best for lots of different reasons. So to really get a sense of what's behind all of the stuff that we're seeing, we have to rely on the whole team. Yeah.
Maggie, I'm thinking about this issue of assessment and thinking about sort of learner satisfaction with the process. I know that when I teach some of the neonatology fellows, one of the most important things I feel like I teach sometimes is that there are multiple ethically permissible paths, that there is not an answer.
Right.
That there's not actually a right answer to the story, that there's a variety of answers, and depending on whose stakes are at play and what kind of compromises can be reached. And so most of the fellows find that unsatisfactory because they're used to the multiple choice question whether it is in fact a right answer. And so I'm wondering how that impacts, I guess, the satisfaction of the residents, and as well as the, what is it that you assess when so often there isn't a right answer?
Good, yeah. So two things. One, in the narrative project, what we're assessing is their reasoning. So just really their level of sophistication about the process, about what their reasoning, not the outcomes. Because it is very difficult to say I have a right answer about the outcomes, especially when I wasn't involved, in the way the case developed. Or even if I am, I'm not one about right answers about ethics. So I think, and I present that to the residents when I talk to them, like, it's not going to be about a right answer. It's going to be about an option, about the options available to you that are ethically justifiable. But it's really going to be all the time. It's always about, I want to engage you in this process because I want to hear what you think about it, certainly as much as I want to hear what I think about it. So I've had pretty good luck with the pediatric residents about this. They're, because they get that they're going to have to come up with a plan. And with me, they get to talk about which plans maybe are not okay. So which of the group are okay, and then they get to decide, it's not, they're not asking me for one answer. With, I think sometimes with the older surgery residents, the second and third and fourth year surgery residents, they get frustrated because they want a rule. They want like, okay, just tell me what to do. And I get that, but we don't, if I could tell them what to do, I would. It's just that doesn't make any sense. So that, sometimes they get a little frustrated, I think, because their time is very precious, as everybody's time is precious to them. So they would like to have something to walk away holding on to that they knew exactly what to do in this situation. I think that's a fact of education. It's just, it's sometimes, it's harder, this notion of accretion, the open your brain and dump in some facts, that's easier for everybody, right? It's easier for the teacher, it's easier for the student, it's just not as useful. So you do sometimes have to just remind people that what we're doing is harder, but in the end more valuable. You're right that satisfaction, it's easy to get frustrated, but I think it's also easy to engage people in the value of this exercise.
One more question, Maggie.
Yeah, right?
Do you have some specific examples in mind when you ask about the possibility of focusing on what is not measurable in ethics training?
So what is not so measurable is, I think, the shared understanding of trying to find a right thing. So the intangibles of virtue are very difficult to measure. So, and that's, I think, that if we could explain to the world, if we could convince the world, even convince Johns Hopkins Medical School, that the right thing to do is to have lots of conversations, lots of open conversations about ethics, just so that it's always in people's minds. I mean, in fact, I think that the more we talk about it, the better we all get at it. That's not very measurable. I mean, I can measure the number of conversations. I can't measure their quality very effectively. That's what's not so tangible. And if I could convince the powers that be that that's enough, then I would stop evaluating and start a lot more doing. But I think we do have a responsibility to evaluate, because I want to convince Yoram that it's going to work in his program. I want to convince everybody that something like that this is worth doing. It's worth taking the time and the money to do this, because it might make a change. But again, I can't really show that it affects, necessarily, I can't show that it affects the way patients experience care, at least not yet. So I think that's still the holy grail. I think we're a long way from. I think there's lots of steps